Okay, good morning. We're going to be doing the shoulder examination today. Thank you, Derek, for helping us out today. But first, what I do when I enter a room, I always just check their posture. A lot of times, most of the patients today, I'll see them humping over like this, slumped over. Again, you note that and you just kind of put it down. Poor posture that can be contributing to their shoulder pain. The next, what I do is I just kind of inspect their arms, inspect the muscle contour, and just make sure, muscle definition along the scapular borders, checking for scapular winging, and I'll talk to you guys about a special test checking for that. Then what I examine the landmarks, and I'm just gonna pull this down. There, one is the AC joint, palpate over here just to make sure there's no tenderness, bicipital groove or bicep tendonitis, bicep issue. Then I examine the trapezius. Make sure there's no tenderness. Over here, you'll feel the spine of this scapula. Above there is the supraspinatus. Below is this infraspinatus, and if you go drop off the spine, then you run into teres minor, teres major. Again, trapezius coming down over here. Below them are the rhomboid muscles, and below the spine below the scapula is the subscapularis. Once I'm done inspecting those, I do the range of motion. First, I have the patient do it. Answer with your thumbs up. Can you go up all the way? All right. First, actually, let's do thumbs up. Go up straight ahead. And then come back down, palms up. Go all the way up to the side. And I have them check both arms, despite them complaining one side. I'd have them do both just to compare from side to side. Let's say Derek wasn't able to go up like he tried and he was only able to go up over here. Then what I do is I tell them, okay, just relax. At this time, they'll be complaining of a lot of pain. So just relax. Okay, take the muscles out. Just relax as best you can. And then I just check out the arm and I just kind of push it up as far as I can go. If I could go all the way full, then you think about rotator cuff issues. But if, let's say, I come over here and I have them stopping, then you got to start thinking about bony issues, adhesive capsulitis, those issues come into mind. And you do that always long. But if they're active, range of motion is normal, you don't have to do this part. Once you have inspected, check range of motion, next is strength testing. So what I do from here is the range of motion. Sorry, I did not go over the external rotation. Is you have them tuck their arm at 90 degrees over here, and you have them rotated out with the elbows tucked in. You do the same thing, and I'm gonna have you turn around. And now bring your arm to the back like you're scratching your back, like about an inch, and go up as far as possible. While I'm here, I also do the lift-off test, just because their arm is there. Push my hand away, There you go, that's checking for the subscapularis muscle. Alright, now just relax, and hold your arms in that 90 degrees elbow tucked in position. So I just hold their arms out like this, and I have them push my hands out, So push my hands out this way, I'm gonna push in. And I'm putting in a fair amount of strength. Like, you're a strong guy, but I'm pushing and stuff. Now, one thing you'll notice is when he was pushing, I felt a constant tremble, but if they're weak, you'll still feel that pressure. So be weak and, keep pushing back, okay? So you'll still feel that, as opposed to if they're not trying and I push stuff in, it'll be like a smooth in. I'm like, okay, you gotta try a little. I know it hurts, but try. And you do that for all the range of motions we did. When you push in, you're checking for infraspinatus teres minor. Pushing out is subscapularis. And then you go in, I do this test. It's called a drop arm test. This is just checking to make sure they're holding their arm up. You keep it at 90 degrees to the level. And then you go push down as well, just to make sure that strength is intact. Keep it up. And then next is this empty can test, which checks for supraspinatus muscle, or the rotator cuff. So I have the rotator cuff strands are running this way, so I try to make it parallel to that. And then I bring this down, thumbs down, and to kind of put more tension on the supraspinatus. And hold this up for me, strong. Again, holding that in, and I do that for a little bit. Then when you bring in the shoulder, you bring it in your hyper AD duct, about 10 degrees in, and thumbs down again. This is going to be checking for labral issues up to slap tear. Slap tear will be positive if I have you hold this up. So don't let me push down, thumbs down, and not thumbs up. Same thing, but don't let me push down. If he complains of more pain with thumbs down, that's O'Brien's positive and you're worried about a potential labral issue. Next part of my exam, then I go do a speeds test, which checks your bicep tendon. And that's pretty much, I tell him, hold your arms out like you're holding a big pizza, okay? And now don't let me push down your arm. And he just push on their palms and have them doing it. Another test that checks for bicep issues is called a Jurgensen. So I'm gonna be shaking your hand, okay? I'm gonna twist this way and then I'm gonna bring your arm up. So we're gonna do that. And I shoulder to shoulder. And I want you to twist this way and try to resist me, okay? So go like that and I bring the arm up. So if that's positive too, you're worried about bicep issue as well. The bicep tendon, not the bicep proximal distal tendon. That's another set of examination for that. Once you do that, then I go into the Neers test, which is checking for impingement. And basically what that recreates is this, so you have the scapula tendon going underneath the hook of the acromion, and the tendon goes through there and inserts at the humeral head. And basically what you do when you rotate their arm in like that, you bring that tendon close to the acromion, and when you do this, and from like 30 degrees, 30 to like 75, if they complain of pain, then that's a positive Neers test, and you're worried about impingement. The next is a Hawkins test, which is you have the shoulder abducted 90 degrees, elbow at 90 degrees, and you internally rotate, externally rotate. If they complain of pain at that point, that's a net positive Hawkins test. Another test for the shoulder is for labral, is the Clunk test. You pretty much hold their arm at 90 degrees test, and you have them, you just labral grind test, excuse me, and if they complain of pain with this, you're worried about labral issues as well. And another is a Clunk test, and you just kind of push this way and push back. If they complain of pain with that, it's positive Clunk test. Checking for shoulder instability, you'll notice that the shoulder contour is smooth and without any sulcus in between. But in patients, younger patients with multi-directional instability, if you take their arm and pull down, and it's an axial traction all the way down, and I'm pulling, you'll notice like he doesn't have anything, but they'll have a divot create, and then you let go and you test that a couple of times. That's for that. Then I'm gonna have you get on the bed and have you lay down, lift your legs. Next I check for, again, a couple of tests for instability is an apprehension test. So what I do is I abduct their arm, shoulder to 90 degrees, take their arm and crank it back. If they complain of pain, that's positive for like rotator cuff issue. But if they complain of pain with or complain of sensation, my shoulder's about to pop out of my socket, that's a positive apprehension test. Again, check. But if you take your arm like this and push down on the humeral head as a posterior direction force, and they say it gets better, that's a positive relocation check. Again, checking for ligamentous instability as well. Next, I do a test while I'm here called the GERT test. And I'm gonna have you lay down over here. Lay down face towards me. 90 degrees this way patient is, arms 90 degrees. And I just rotate the arm down. You got positive, you gotta work on this. So, so normally a patient should be able to touch the bed. And that supposed means that the posterior capsule is tight and you need to stretch out a lot more. And so that's GERD, that's just checking for glenohumeral internal rotation deficit, and that's just posterior capsule tightness. And that concludes my shoulder exam. If you guys have any questions, always feel free to reach out.